So, good evening, friends. Eh, Nobody's there to give my introduction, or should I start as such?
Sir, viewers are on another link,
Okay,
sir. Web link, sir.
okay, okay. So, good evening, friends. At the outset, I must thank Lupin team for organizing today's webinar and giving me an opportunity to interact with my fellow colleagues across North Zone. And once again, I welcome you all for today's meeting. Today we are going to focus on insulins and its ever important role and relevance, and why I have chosen 2020. There is only 2 3 days left in 2020. 220 is only short living now, 2 or 3 days being left now. But important thing is to learn that insulin, the most potent glucose lowering molecule and placed as a miracle of 19th century, is going to be 100 years old, in 2021. So next year, that means 2021, is the centurion year of insulin. So we are going to discuss about its role, its relevance, how to initiate insulin, how to optimize insulin, and how to intensify insulin. It's a sort of case-based scenario. It's a sort of workshop. Now, indications for insulin use, insulin therapy. On one hand, it is very much clear that absolute indications are type 1 diabetic patients, diabetic ketoacidosis, hyperosmolar hyperglycemic state, diabetes in pregnancy, patient who is severely insulinopenic with marked osmotic symptoms, marked catabolic symptoms. There are clear indication of insulin. Also under stressful condition, when your patient is in ICU, patient is in HDU, you require insulin for management, and also in perioperative management of glycemia. So insulin is a sort of rescue therapy, life-saving therapy in such type of scenarios. But the most common indication is type 2 diabetic patient with failure to achieve glycemic control on adequate amount of OADs, that is 2 or 3 OADs in number. So this is the most common presenting symptom, most common presentation where you require insulin in type 2 diabetic patient. Also, if there is presenting high glycemic load or high glycemic parameters are there, like HbA1c more than 9%, fasting plasma glucose more than 200 milligram, postprandial plasma glucose more than 300 milligram, at these time also it is prudent to start insulin. So basically, these are the indications where you require insulin in management of diabetes. So, so insulin is the need of hour. But is insulin the need of hour? It's a very pertinent question, and we will be going to spend some minutes or for this on this slide, because it is very important and few points are need to be emphasized when you manage your type 2 diabetic patient. Number one is that you all agree that we generally consider type 2 diabetes as a progressive nature disease with ongoing beta cell dysfunction. Beta cell function goes on going down irrespective of baseline OADs which you are using. Secondly, most of the treatments available to control glycemia, like sulfonylureas, or you can take DPP-4 inhibitors or GLP-1 analog, or even metformin, are basically targeting either beta cells of pancreas or insulin resistance, and they are dependent upon presence of native insulin. Some amount of insulin should be there from secretion from beta cells of pancreas for their therapeutic efficacy. Yes, SGLT2 inhibitors, they don't fit into this classes, and it's an exceptional class with different mechanism of action. But otherwise, other class of medications of glucose lowering agents, they require some amount of beta cell function should be there. Number three is that durability of these medication, it varies. Sometimes you can say SUs has got lowest durability, whereas gliptins has got better durability, TZDs has got again better durability, but metformin again has midway between these two durabilities there. But the durability of medication varies, and their safety is occasionally under scrutiny. You all know that. But fourth very important point is that over a period, patient fails to achieve or maintain A1C goals, even with adequate amount of lifestyle medication, optimal dosage of multiple OADs, and will require insulin therapy. And this happens in most of type 2 diabetic patients, around 50% and more than 50% of type 2 diabetic patients over the years of 5 to 7 years during the course or during the journey of type 2 diabetes. They require some amount of insulin to manage their glycemia. Also remember that adequate or optimal dose of that is of OAD do not necessarily, it is not necessarily means that highest administrable dose. For example, doubling the dose of sulfonylureas or even gliptins or even TZDs doesn't make much sense. Doesn't make much sense. Or you add some another drug, it doesn't make much sense if their glycemic load is on higher side. So doubling of doses of these agents doesn't increment their effect. And usual optimal dose is, you can say, for sulfonylureas is half of the maximal dose. That means if you are using glimepiride, maximal administrable dose is 8 milligram. Whatever the optimal effect is coming, it is up to 4 milligram per day. Beyond that, you will not get much incremental benefit in glycemic control. But practically, if we see how much insulin we are using, do you know what is the average A1C in India at which insulin is initiated? Friends, it is more than 9.2%. It is most of the time we are delayed using insulin usage. And also more important, what proportion of type 2 diabetes patients are being prescribed insulin? When I'm telling you around 50% of type 2 diabetic patient will be requiring insulin, but what is the number of patients with of type 2 diabetes which are on insulin being prescribed by us? It is only less than 22%. So it's a very low usage of insulin, very late usage of insulin. And if it is initiated, if at all we initiate insulin, the dose up to which the basal insulin is up titrated or optimized or intensified is only 18 unit. So it is underutilized, late utility of molecule and delayed utility. Or so this is the clinical and therapeutic inertia of initiation of insulin. And it is most of the time it is often delayed by up to 8 years. And by the time insulin is initiated or considered, patient already developed bad glycemic memory for 10 to 15 years and have already developed micro and macrovascular complications. And if we add, you all know there is a dysglycemia preceding type 2 diabetes 10 to 15 years back. There is preceding pre-diabetic stage, which is a stage of dysglycemia, progressive dysglycemia, impaired glucose tolerance, then impaired fasting glucose, then type 2 diabetes. So if you add 10 to 15, this again you add, then the total amount of dysglycemia will be 20 to 25%, 20 to 25 years. So such a huge glycemic burden already there when you consider or when even you think about insulin. So the friends, the best practice, best approach is to ensure timely initiation of insulin. If you want to prevent or delay or postpone micro and macrovascular complications in your patients, then of type 2 diabetes, it is timely initiation of insulin by overcoming this therapeutic inertia without undue delay in insulinization. Once you have initiated insulin, it has to be optimized. It also to be intensified. So once your optimal combinations of OADs are not working, you are seeing that two or more than two, up to three OADs are not working, it is no fun to add or even up titrate the dose of OAD. Now we are going to apply this concept of timely insulin initiation, optimization, and intensification of insulin. We will be going through some case simulation studies. So here is a case one. He is 62-year-old female patient, history of type 2 diabetes for 7 to 8 years, treatment on metformin 2 gram per day. It's okay dose for metformin, glimepiride already optimal dose of 4 milligram per day. She has got osmotic symptoms, that means polyuric polydipsic. So polydipsia and polyuria is there. Weight is 60 kg per and body mass index is 24.8. So she has got osmotic symptom, long duration of diabetes, but still she is not that prolonged. She is 7 to 8 years. and the glycemic load is very high, as you can see here. Fasting plasma glucose of 288 and postprandial glycemia of 340, HbA1c of 13.4, urinary albumin creatinine ratio of 400 milligram per gram. That means already macroalbuminuria is there. So if you see this FPG and PPG, you just have a difference between PPG, that is, and FPG is 60 milligram. So what this patient requires, I think everybody is now is should be agreeing with that this patient will be requiring insulin, because it is HbA1c is 13.4. If you are you are not going to get targets of 7% A1C, or even even 7.5% of A1C in this patient, even by adding 2 or more OAD. They are not going to give you any benefit. Of maximum benefit you will get by adding 2 OADs will be around 1.5 to 2%. That is maximal. And still you will be off target by 9%. 9% will be the achieved target, and you will be off target. So if you want to achieve this target, and patient already has got osmotic symptoms, catabolic symptoms are there, osmotic symptoms are there, and she has got macronuria already there. So this patient is a fit patient to need for insulin. So we all agree that we should start insulin in this patient. What type of insulin should we prescribe in this patient? It's a very pertinent question, and it always comes in our mind that which type of insulin this patient should be fitting into. Second, what should be the initial starting dose of insulin? We will discuss this thing in length. Now, before discussing what type of insulin we should start, but why we start insulin, why we give insulin. So insulin treatment is intended to mimic the physiological secretion of insulin. Whatever insulin you are giving, you are basically trying to mimic the physiological secretion of insulin. So insulin treatment is intended to mimic physiological secretion, and which occurs in two forms. You know that physiologically that beta cells of pancreas, they secrete insulin in two forms. That is, number one is basal insulin secretion, that is a continuous round the clock peakless secretion of insulin, 0.5 to 1 unit per kg body weight, per 0.5 to 1 unit per hour is the secretion of insulin. That is a basal insulin secretion, making a plasma concentration of around 5 to 15 micro unit per ml. So it's a basal continuous peakless secretion. That is also in pulsatile form, but it is a continuous peakless secretion from the beta cells of pancreas. Secondly, there is bolus insulin secretion, or you can say the perindial insulin secretion. So in perindial insulin secretion is in response to metabolic challenge as carbohydrates or meal respond, and is observed in two phases. So first phase of insulin secretion, that is a rapid or brisk or electric like secretion of it's just like rapid secretion of insulin. It's a transient phase. It's a first phase of insulin secretion. It's a transient phase, and it returns to basal level within 5 to 10 minutes, reaching up to nearly maximum of 60 to 80 microunit per ml. Second phase, that is the second phase, will be there, that will be following this first phase of insulin secretion, and it will be a sustained plateau phase, and this is lasting for around 2 hours. So this is the type of basic insulin secretion, and we try to mimic in our practice, we try to mirror this type of physiological insulin secretions. We have various type of insulin preparations that are available to us. There are short-acting insulin, that is regular human insulin, that is human actapred or insulin, human insulin R. They are regular insulin, and there is Lispro, Aspart, Glulysin, and there is ultra short-acting, that is much more physiological insulin, that is FASP insulin, that has got shorter duration of action, very rapid onset of action, high peak effect within first half hour. 30 minutes of there is a very high rapid peak of insulin secretion, and better glycemic control in 1 hour of the postprandial 1 hour. It's a better glycemic control with FAST. Then you have got intermediate or long acting insulin. It is NPH insulin, which is a typical intermediate acting insulin. Glargine, U100 and U300. Detrimet is somewhat not available nowadays, but Teglutech is there. That is a ultra long acting and third generation, or you can say fourth generation basal insulin analog. Then you have got various permutation combination, or you can say premix insulin, 30 to 70 milligram, so 30 to 70 unit regular NPH mix, that is most commonly used, mixtard and or 30-70. Then you have got analog mixture also, novorapid mixed with the that is aspart and aspart. It is that is NPH, which is aspart linked as, so it's a 30-70. Again, then you have got lispro mix, so protaminated aspart and aspart is there. So 25-75, and then you have got mid mix, that is 50-50 mixture is there. Then you have got a newer formulation that is known as co-formulation. That is not a mixed form. Both molecules are working in a different pharmacokinetic dynamic profile is maintained as such. There is no interference in between these degludec and aspart, newer addition of co-formulation. Now, going to the classification of human insulin, we classify them according to their onset of action, time action profile, their peak action, and their total duration of action. So short-acting insulin, 0.5 to 1 hour of their onset of action. That's why they have to be taken by 30 to 40 minutes before the meal. Then peak action comes at 2 to 4 hours, and there is a protected prolonged tailing, that is 4 to 6 hours with short-acting or regular or soluble insulin. Then intermediate acting, that is NPH, and that starts working by 2 to 4 hours. Peak is there, that is around 8 to 10 hours after the first that index dose, and then total duration is around 12 to 18 hours, and you have to give BD dose of NPH insulin. Then you don't have lenti long-acting insulins. We do have long-acting, but lenti and ultra-lentis are not available with us. Then premix insulin, onset of action is dependent upon the rapid acting or regular acting insulin, and duration of action depends upon the longer part of the mixture. So short acting insulin are, that is insulin analog. These are lispro, aspart and glulysin. Onset of action is 5 to 10 minutes. Peak action is 60 to 120 minutes. And total duration much more truncated duration of action in comparison to your regular human insulin, that is 3 to 4 hours. Then long acting insulin are glargine, that is onset action 0.5 to 1 hours, but they don't have peak, but slight peak has been there with the glargine 100 also, U100 also, and total duration of action is just short of 24 hours. Detrimer, you have to give BD dose. Degludec is the ultra long acting drug. It has got total duration of action of 3 to 7 hours. And then you have got premixed, short acting with protaminated aspart or protaminated lispro is there. So that is giving you onset of action of just 5 to 10 minutes, duration, peak action 1 to 8 hours, and duration depending upon the longer duration of the component. So 12 to 18 hours. So they are there, short acting, rapid acting, analog insulin, regular human insulin. Then there are longer acting, long duration of action, intermediate duration of action insulin, and there are mixtures also. So going back to our case, 62-year-old lady was there with high glycemic load with HbA1c value of 13.4, and then patient was having urinary albumin creatinine ratio, glycemia under not well controlled. So now usually there are two choices to initiate insulin. Usually there are two choices. Either we initiate with a basal insulin, that most of guidelines they say, and the dictum is that once you start with basal insulin, that is you are following the dictum of fixing fasting plasma glucose first, or you can start with premix insulin, taking care of both fasting plasma glucose and postprandial glucose together. Now with basal insulin, we must remember it is easiest to start with basal insulin, and most of the guidelines, specifically if you focus on international guidelines like ADA, ESD, ACE guidelines, they still prefer basal insulin as a initiation of insulin. But our guideline like RSSCI guidelines and NICE guidelines and the Canadian guidelines, they also has an oblique of premixed insulin or even co-formulation can be for a initiation in type 2 diabetic patient. So two things, once you started thinking that you start with basal insulin, so you have to remember two things. Number one, we control fasting plasma glucose with basal insulin. Basal glycemia gets under control and fasting plasma glucose gets under control. And we continue with the all OADs, be it SUs, be it DPP-4 inhibitors or metformin, which are taking care of your postprandial rise and decreasing insulin resistance. So they are to be continued in basal insulin therapy. So we require, that means we require some amount of beta cell function should be there so that your failing oral antidiabetic drugs, which were not working in your patient, should be now able to have insulin secretory effect, adequate amount of insulin secretory effect from your beta cells of pancreas. So if you want to initiate basal insulin, it should be much more earlier in your algorithm of type 2 diabetes management. More you delay, more the glycemic load is there, more HbA1c on higher side, more postprandial contribution comes, then you have to switch over or you have to start with premix insulin. So if you want to start with basal insulin, it should be more proactive approach. Secondly, if we continue with basal insulin plus OAD, only 40% of your type 2 diabetic patient will come under target. That means around 7.7% A1C will be achieved in only 40% of your patient. Rest 60% patient, they will require some amount of intensification of this basal insulin in the form of either you have to go with basal plus one, that is one with a larger meal, a bolus insulin with larger meal, continuing with basal plus OAD, or you can continue, you will have to switch over to basal plus 2, or sometime you basal bolus therapy, that is boluses, 3 boluses plus 1 basal therapy, plus, or there is another option that is basal plus GLP-1 analog. So you have to intensify in 60% of your patient who are on managed with you, who you are initiate with basal insulin therapy. And what the guidelines I have told you, that all international and Indian guidelines, even RSGI guideline, they recommend insulin initiation either with basal insulin or premix insulin or with co-formulation, except your ADA, ESD, ACE guideline, which prefer basal insulin for initiation. Practically, how we decide, how we say that this patient should be started with basal insulin or with premix insulin. So you obviously you will want your initial step should be more accurate and more scientifically justified. So the best way is to rely on glucophenotype of your patient. Your patient glucophenotype, how much glycemia is there, what is A1C is there, how much fasting plasma glucose and how much postprandial excursion is there, disease severity, and also meal patterns, whether patient is able to take 3 meals, and also ability to self-inject or at specific time of the day. So these are all important things when you consider which type of insulin you have to initiate. And we look at fasting plasma glucose and postprandial glycemia together. And if we see different FPG and PPGs in a separate way, so we will not be hitting the target. A1C, FPG, and PPG should be in focus altogether. Why? Because if there is a excursion of more than 60 milligram between postprandial glycemia and fasting plasma glucose, and from where this 60 has come, it is from the 140 of postprandial, that is normal postprandial 140, and the 200 milligram is the postprandial, that is a diagnostic of type 2 diabetes. If you divide, if you have a difference between it, it comes as a 60. So 60 milligram is the cutoff. It's a rough cutoff value, that if it is more than 60 and more than 60, then your patient preferable choice should be premix insulin or a co-formulation. So here in this patient, you can easily make out that there is high glycemic load, there is high A1C. So such type of patient should be started with premix insulin. So here we started with premix insulin analog. Patient was affording, and so we started with insulin Lispro 2575. So if we start now, how to start with, what should be the initial dose? Second question. That second question was that how much should we start? If we start OD dose of premix, suppose we start with OD dose, it should be started 10 unit, rough 10 unit, that is nearly a dictum, that we start with 10 unit of insulin, premix insulin as a starting dose, OD dose with a major meal, or it's most of the time it is before breakfast or before dinner. It all depends. We will discuss it. Or if you are starting with a BD dose, then they say that 6 unit BD dose for 6 unit in the morning before breakfast and 6 unit before dinner as an analog insulin. Or if it is better to start to calculate as a total daily dose. So how to calculate total daily dose? It is 0.4 unit per kg body weight. That will give you TDD, that is total daily dose. And that total daily dose, if you are using regular human insulin, that is to be divided 2/3 in the breakfast part before breakfast and 1/3 before the dinner. So, or if you are using analog insulin, then half of in the morning and half before breakfast and half before dinner or your supper. So that is the usual way that we start with premix insulin. Now, how to do titration? You started with it. You try to achieve glycemia, and what should be the target? If you are using morning break, you have to titrate the morning dose. Then two values are important. You have to look for the two values. 2 hours. One value is 2 hours after breakfast, and second is pre-dinner value. So you have to target these two if you're targeting pre-breakfast, if you're using pre-breakfast premix insulin. And if you're titrating pre-dinner premix insulin, then you again have two values to be considered. Number one is 2 hours after dinner and pre-breakfast value. So these two values are to be checked, and you have to fix these two values before for up titration of the dose. Now here, this patient was calculated as a 24 unit per day. So we started with 16 unit in the morning and 8 unit at evening. So we do have evidence to prefer premix insulin over basal insulin. So it's a Malone study, Malone study, that was Malone et al. They published this study in Diabetes Medicine 2005. And the study was, the aim was to compare the glycemic control of an insulin Lispro mixture, 25% to 75% mixture, BID dose, 2 doses with metformin on oral with comparison to OD dose of insulin glargine plus metformin. And the study design was multicentric, randomized, prospective, open label, and importantly, it was a crossover study. So after 6 week lead-in period, the patient were randomized, assigned to treatment with either the insulin Lispro mixture before breakfast and dinner plus metformin was continued as 1500 milligram to 2500 milligram per day, or insulin glargine at bedtime plus metformin, again the same dose for 16 weeks. And after getting this, after completing this 16 weeks, there was a crossover period. That means opposite treatment was given. Just you can understand from this chart that there was a lead period, then there was a 16-week period of comparison of glargine plus metformin, Lispro mix, BID plus metformin, and after 16 weeks, the population was just crossed over. So those patients who are using Lispro mix, they were shifted to glargine plus metformin, and then those patients who are on glargine plus metformin, they were shifted to Lispro mix 25 BD dose of metformin. So conclusion came that at the end of 32 weeks, patients who were treated with Lispro plus metformin, they showed significant decrease in A1C as compared to patient treated with glargine plus metformin. So there was better glycemic control with usage of premix insulin plus metformin in comparison to glargine plus metformin. So these were treat to target trials, and they were trying to achieve the targets. Up titration was advised in both groups. So you can see that there is comparatively better glycemic control with premix insulin. So benefits of Lispro plus Lispro mix plus metformin combination, it is associated with significantly greater A1C reduction at 32 weeks. It enabled a larger proportion of treatment population to attain A1C of less than 7%, despite significantly higher fasting blood glucose. So fasting plasma glucose was somewhat better controlled with glargine alone plus metformin, but here even had slightly not significant numerically poorer control of fasting plasma glucose, but overall HbA1c was much better controlled in premix insulin plus metformin. Improved glycemic control after breakfast and after dinner resulted in higher overall hypoglycemia rate, slightly because you have added here prandial insulin, slightly minor hypoglycemia are there, but overall severe hypoglycemia and nocturnal hypoglycemia were not increased. They were exactly similar. So not having much more adverse events in comparison to both arms. So with this much evidence, so we started with premix insulin. But if we start with basal insulin, what should we do? If we are starting with basal insulin, suppose you think that let me try with basal insulin, what type of what should be the usual starting dose? Most of the time we start with basal insulin, we start with 10 unit at night before at a fixed time. So we start one, say glargine is started, lentus is started at 10 unit at chest, say as at a time of around 10 p.m. So why we start with 10 unit? It is not a hard and fast rule, but there is some science involved. Is that which has a this 10 unit has got minimal if chances of hypoglycemia, that you are initiating insulin. Obviously you will not want any sort of hypoglycemia, because even if you have minor hypoglycemia or even other hypoglycemia, there is always a shaking, you can say, compliance or adherence to a doctor. Patient will have lesser compliance, or you confident. It's a sort of, one of the thing is that there is a confidence losing thing, that is hypoglycemia, if you initiate with insulin. And you know how to take care of this psychological resistance from patient's mind and also from physician's mind of initiation of insulin, and you got this hypoglycemia again, then that can lead to lot many adherence effects. So you are going to lose patient if you find any, you are have any hypoglycemia. So 10 unit has got minimal chances of hypoglycemia. Initiation with 10 unit, you have got minimal chances of hypoglycemia. And also it is a sufficient amount of insulin to decrease hepatic glucose output. So 10 unit is the dictum. Otherwise, you, if you want to be more precise, as per, you can choose, have A1C value and also body weight. If your A1C is less than 8% and you are initiating basal insulin, that starting dose is 0.1 to 0.2 unit per kg body weight. It is most of the time 50 to 60 kg person, it comes around 10. So 0.1 to 0.2 unit per kg body weight should be the initiation dose. And if you have got A1C more than 8%, then you can go up to 0.2 to 0.3%, 0.2 to 0.3 unit per kg body weight. And you have to titre more. I go with the titration of 1 unit per day to achieve a fasting plasma glucose of 110. Then I allow my patient to have 1 unit per day, or you can go with 2 to 3 unit every third day for up titration of dose, that to get the optimal fasting plasma glucose. Now, if you are starting with co-formulation, that is a combination of IDEC aspart, that is a IDEC aspart. So here, that is a degludec plus insulin aspart is there as a co-formulation. So it is most of the time co-formulation is basically as a sort of meal time bolus. That is large, you choose a largest meal where you give co-formulation before that largest meal of 20 minutes before that largest meal. Suppose it is a lunch or it is a dinner. You give me, it's a meal time bolus with 24-hour basal coverage. So best to start with single dose 20 minutes before the largest meal with the dose of 10 unit. So that is there. Or you can calculate total daily dose by 0.4 unit per kg body weight. So, and also if patient is obese or highly insulin resistant, then you can have calculation of around up to 0.5 or 0.6 unit per kg body weight, and you divide in 2 equal half. If you are giving BD dose of co-formulation, then it is 0.4 unit per kg body weight in a patient having body mass index of 24 or less than 24. And if it is more than 24 or patient is obese and you are suspecting high insulin resistance, you can go up to 0.5 to 0.6 unit per kg body weight and divide into 2 equal half and give it in a BD dose. So this is the action profile of most of the insulins that has been included here. You have seen that there is analog insulin like Lispro, Aspart, and Glulysin, and whereas shorter acting insulin, then there is intermediate acting insulin, long acting insulin detemir, and also long acting glargine is there. You have got high concentrated glargine available with us U300, and then you have got degludec, that is a longest acting ultra long acting basal insulin. And FASP is somewhat more physiological. It is somewhat more nearly, it is more physiological insulin. It is better than even your Novorapid or even Lispro. So coming to case scenario 2, so it's this is the patient, 64-year male patient, history of hypertension, asymptomatic ischemic heart disease. So already he has got macrovascular complication and comorbidities, type 2 diabetes for 27 years. That means very severe, very long duration, very prolonged duration of diabetes is already there. Then there is higher age, lots of comorbidities like severe peripheral neuropathy, complication, microvascular complication. Already patient has got proliferative diabetic retinopathy. For type 2 diabetes for 15 years, he has got this proliferative retinopathy is already there. So it's a very sick patient, very tough patient to treat, because you don't want any sort of hypoglycemia in this patient, and you have to control glycemia to an adequate amount of HbA1c target of at least around 7% without hypoglycemia. So you definitely require insulin in this patient, and patient was already on regular insulin, plus there was three doses of human actapred, or you can say regular human insulin R was given 3 times, plus there was degludec as a basal insulin was used in this patient. So he was already on insulin of basal bolus therapy for 9 years. But the lab data on first visit was, you can see here, 90 fasting plasma glucose nearly okay, 98 to 140. Postprandial glycemia is not that higher, 150 by 180, but HbA1c is 8.2%. So that means there is somewhat, this is pre-breakfast and post-breakfast blood sugar level. So single shot, remember that, single snapshot of fasting plasma glucose and postprandial glycemia, if they are not matching HbA1c, that is, there is a discordant between your blood sugar values, lab values, and HbA1c value, that means your patient requires continuous glucose monitoring or ambulatory glucose profile. That is required because you have to look at other meals and other contributions of these meals towards postprandial rise. So CGMS, or you can say from CGMS, or we get whole glycemic profile, as you can see from the right side of your screen, that CGMS, continuous glucose monitoring system, was used here. We get whole glycemic profile for say 5 to 7 days, or even up to 14 days if you are using Abbott Freestyle Liber AGP ambulatory glucose profile, which I am using very regularly. That gives us an excellent compressed, that it's a compressed picture of glycemic variability or glycemic fluctuation, in addition to your hyper and hypoglycemia. So you can see that mean average blood sugar values will be there, then there is a target in time in range value will be there, time above range values will be there, and how much time below where range is there, that comes with CGMS or AGP profile. So the excellent tool that can answer the query why still having nearly normal fasting plasma glucose and postprandial glycemia for PPG values, you have got higher HbA1c. So here on observation on the first visit, A1C was high, as along with post meal spike even on regular insulin. So you can see here that postprandial rise both are there at the time of lunch and also at the time of dinner, and somewhat higher even after breakfast. So patient already on regular human insulin plus degludec, and looking at these spikes, we started with more better physiological or analog insulin, because now we think that we have to up titrate the dose of regular human insulin, or regular insulin has to be up titrated to achieve this HbA1c or glycemic targets, and you don't want to have hypoglycemia. So there is definite hypoglycemia benefits, nocturnal overall hypoglycemia in analog insulins. Rapid acting analog insulins has got an edge over regular human insulin. So we added Lispro here, and we removed regular insulin. We continued with degludec. So 3 months later, on Lispro and degludec, you can see that absolutely clear, flatter profile. More of the time, patient is in time in range, and postprandial meal spikes were improved along with improvement in HbA1c value. So this is the beauty of CGMS and ambulatory glucose profile, and looking at that data, you can alter, you can change the therapy, and you can get the benefits, and patient will be benefited. Now, insulin once initiated must be optimized, meaning that to achieve fasting plasma glucose or postprandial glycemic excursion, you have to put them under the target, avoiding hypoglycemia, and up titration or down titration is required. So that is known as optimization. And if further deterioration occurs, suppose further spikes are coming, we have to move to intensification of insulin therapy. So when to intensify, why to intensify, why to optimize, and how to intensify. It's a beautiful graph that has been shown here. So when HbA1c is not on target, so why? Because FPG is not at control, not on target. Then you have to go to the basal premix insulin up titration. Or if FPG is at target, postprandial glycemia is not at target, you have to intensify the premix insulin, or you have to add prandial insulin, or you have to start with GLP-1 analog with basal insulin. So this is the way to look at the values. Then suppose your HbA1c is at target, but frequent hypoglycemia is coming. So then you have to de-escalate or down titrate the dose of insulin. Insulin down titration or change of insulin regimen is required. So if you have a starting regimen, that is you are starting with basal insulin plus OAD, then what are the intensification regimens you can continue? That you have to go to basal plus insulin. That means adding basal insulin. With basal insulin, you add one prandial or two prandial insulin, that is basal plus 1 or basal plus 2. Or you have to shift your patient to premix insulin, that is BD dose of even TID dose of premix insulin. Then, or ultimately basal bolus therapy. If you are starting with premix insulin, OD dose or BD dose, then how to intensify? You can make OD dose of premix insulin as a BD, and if you are using BD dose of premix insulin and you are using analog insulin, here is a beauty that you can even start triple dose of TID dose of premix insulin analog. And also ultimately, if still patient is not managed properly, not getting proper management of glycemia, then you can go to basal bolus therapy. So this is how the starting regimen can be optimized and can be intensified. And if you are using only parenteral insulin, sometimes this happens, like in type 2 diabetic patient with pregnancy, and also in sometime in CKD patients where you require only parenteral insulin. If you started with parenteral insulin, single shot or two shot of parenteral insulin, not using any basal insulin, still if you want to intensify, then you add basal therapy. You make it a basal plus therapy, or you shift your patient to basal bolus therapy. So this is the way of starting regimen and intensifying the regimen, because it is not the starting, that is, it is not the inertia at the level of starting or initiation of insulin. Inertia is already there at the level of optimization and also at the level of intensification. So you have to take care of all these three hurdles. Now, most of the time, MDI, that is multi-dose insulin, or you can say basal bolus therapy, is rarely done in routine type 2 diabetic patients. It's rarely. Exception is that when you have got patient in hospital setting, like HDU or ICU setting, or a perioperative management. So most of the time we go at that time basal bolus therapy is being used, because in it is but it is a most physiological type of insulinization. And always basal bolus therapy, you require more pricks, more number of pricks will be there, more SMBG, that has to be more frequent, and carbohydrate counting has to be told to your patients to look at the bolus therapy, how much bolus has to be injected. So it's a definitely it is more demanding, and highly patient should be very aggressively monitored when you put your patient into basal bolus therapy. Now, usual concept, this is another concept that has to be highlighted here, that usually the concept is that when HbA1c value is more than 8.5 or higher, fasting plasma glucose has got maximum contribution towards A1c values, and below 8.5 towards 6.5, it is postprandial glycemia which has got more contribution. It is from Monami et al. Study, Monier et al. Study. So it's a Monier data that shows that HbA1c value from 8.5 towards 10%, that you have got more fasting plasma glucose contribution, and moving back from HbA1c of 8.5 towards 6.5, you have got more contribution from postprandial glycemia. That is Monier et al. But Asian data, that is Wang et al. Study, that is very different. That says that here we have 70%, because Indian scenario is very different. Because carbohydrate, if you look at consumption, it is more than 70% of our daily calories that comes from carbs. And most of the time, 60 to 70% carbs we consume, that is a refined carbs. And also our postprandial glycemic excursion is on higher side, is much more higher in comparison to Caucasian or Western counterparts, if you even if you give a similar amount of carbohydrate load. So our excursion is on higher side, high glycemic variability is there, and our carb addiction is definitely there. So leading to high postprandial glycemia contribution versus fasting plasma glucose contribution across all the ranges of A1C, whether you are at 8.5 towards 10% or 8.5 towards 6.5%, your postprandial glycemia load has got more contribution at all the values of A1C in Indian scenario. So in Indian scenario, we cannot just ignore postprandial glycemia and cannot only try to fix glycemia by managing only for the fasting plasma glucose. Also, to manage these glycemic excursions, we have highly more concentrated insulin preparations, and that is glargine 300, that is a 20 that is there with prolonged duration of action by giving it a more concentrated form. It has got slow protracted release, but requires 20% higher dose of glargine in comparison to Lantus or glargine U100. Duration of action is 36 hours. Lispro concentration, concentrated Lispro is again a very good addition, that it has got duration of action of near exactly same as Lispro 100 unit, but it is more concentrated. So higher concentration insulins are used in patients with severe insulin resistance and high insulin requirement. And this severe insulin resistance comes when your patient is in HDU, ICUs, infection, sepsis, and in COVID patient. We struggled a lot in managing glycemia in COVID-19 pandemic. We started with using insulin infusions. Insulin infusion dose goes to around 200 to 250 unit per day, but still glycemia. Plus, you have to add some more boluses, and around 250 to 300 unit insulins were given. But patients who are on steroids, who are having high cytokine storm, high inflammatory burden, they were very tough to control glycemia in COVID-19 pandemic. So here we used this highly concentrated insulin. Patient obese, patient has severe insulin resistance or insulin resistance syndromes, patient on steroids, their highly concentrated insulin is really a boon. So, and there is a pen device, exactly same cost as you have got Lispro U100, and gives you remarkable and with same pharmacokinetic and thermodynamic profile as Lispro U100, but highly concentrated, so lesser volume is given, better pharmacokinetic thermodynamic profile is there. So it's a beautiful add-on. Again, you have got glargine U300, regular U200 are currently also available in India. While regular insulin is not usually prescribed in developed country, but we are all using, it is not that we are promoting analog insulin. We should not think like that. Insulin is insulin. If you want to achieve glycemic control, any type of insulin can give you adequate amount of glycemic control. They are all equally as per A1C is considered. It is only difference is how safely you achieve the target. How much total hypoglycemia, how much you can say minor or moderate hypoglycemia, how much severe hypoglycemia, and how much nocturnal hypoglycemia is there. So that is the safety of insulin that gets improved when you use analog insulin in comparison to regular human insulin. Otherwise, glycemic excursions, glycemia control, all are exactly similar. Now, if you are initiating with premixed insulin, as from I will go directly to this, that prescribing insulin, that means you have to educate your patient about insulin injection devices. So there are different devices, there are pen devices, there are vials and syringes. You have to advise your patient regarding types of vials, the concentration U100, U100 or U40, and You have to match it around with U100 U100 syringe with U100 vial, and U40 syringe with U40 vial. So that should not be any interchange in between that. Otherwise, the concentration, otherwise the dosage will be very erratic. Other best is to use insulin pens. That is there. Ergo 2 pens are very good pens, and also Novopen 4 is very good pens. So, and also Lentex has got its own pens. So pen devices are there. You have to familiarize your patient. Injection devices, then storage during travel, specifically important. When in summers the temperature goes above 45 in our north zone, so here you have to advise your patient to use a coolant, use an ice cool packs. So ice water should be used, and never to put the vials on the, or the pen fills on over the ice. It should be in ice cool water. Then insulin injection technique has to be done, has to be taught to your patient. So in injection sites where it has to inject, mixing insulin, needle reuse, and needle change of site. It is very important to have a better compliance, better results because of lipohypertrophies and many issues. Then disposal of sharps should be told to your patient, and hypoglycemia management. So it's a whole baggage of education that has to be given to a patient or the caregiver once you are prescribing insulin. It is not only giving a prescription of insulin and your job is done. It is not done. It is not. It is only 10% job you have done. It is not only choosing of insulin and setting the dose. You have to tell your patient. You have to educate your patient regarding all these things. So it's a lot more education, and you have to spend your time. And here the role of diabetes educator or diabetes nurse comes in a very big way. Now, if we now, I'm going directly to the. I'm skipping these case studies. They are. I will go to this algorithm. Now, initiating premixed insulin. This is from RSSDI and Endocrine Society combined guidelines. Patient who is with, we start with lifestyle modifications, healthy diet, control of weight, and adequate physical activity. We start with metformin, failure to achieve A1C goal of less than 7 after 3 months of metformin therapy, and your patient having HbA1c value of more than 7 but less than 7.5. Then you say that metformin plus OAD plus GLP-1 analogs, they are preferred agent. Now, most of the guidelines, they are preferring GLP-1 analog are the preferred first line injectables over insulin due to their effect on atherosclerotic cardiovascular disease with significant MACE benefits and renal benefits in patients who has got established atherosclerotic cardiovascular disease or a multiple risk factor over and above their glycemic reducing benefits. So GLP-1 analog has got benefit, and they have got equal effect to even basal bolus therapy of reduction in glycemia and getting fasting and postprandial glycemia under control. So we have got enough data that has compared with GLP-1 analog in various trials, and they are preferred agent in comparison to insulins most of the time now. But if your patient still is not able to achieve glycemia of less than 7% after 3 months, then metformin plus premixed insulin OD or BID dose has to be selected, because after GLP-1 analog, they are not failing. They are failing with metformin and OAD. It is only with the premixed insulin that has to be started. There is no fun in using basal insulin once it has been tried. So otherwise, if you have got A1C value of more than 7.5 up to 8.5, then you have to start directly with metformin plus premixed insulin analog. Premixed insulins may be regular or insulin analogs. You can prefer depending upon the cost, efficacy, and other issues that has been highlighted. And A1C still above 7 and fasting plasma glucose of 110, then titrate premixed insulin to BD dose to achieve fasting plasma glucose of 110. And if A1C is more than 8.5, again metformin plus premixed insulin BD dose has to be started, and you have to intensify it, and still not getting control by after 3 months, then you can go up to TID doses. That means 3-time dose of premixed insulin analog has been advocated. Now, you can start with OD dose. That means 0.1 unit to 0.2 unit per kg body weight, or I told you 10 unit. Initial premix OD dose. Then if pre-dinner is on higher side, morning dose has to be increased. If pre-dinner pre-breakfast is on higher side, evening dose has to be increased, that is up titration. And if reaching more than 30 unit dose per day, single OD dose, if you are reaching more than 30 unit per day per day dose, single dose, then you split into two equal half, that pre-breakfast and pre-dinner. So OD dose 0.1 to 0.2 unit, you start either before breakfast or before dinner. Then you have to up titrate according to the blood sugars values I've told you. Morning dose up to with the pre-dinner value, and evening dose up with the pre-breakfast value. Then this is to be up titrated. And if you are up titrating it and you got that you are achieving this or partially achieving it with dose going above 30 unit per day, then it is better to split into two equal half, pre-breakfast and pre-dinner dose. Otherwise, straightway BD dose with usual omission or markedly decreased sulfonylureas. We always decrease, say it is 2 milligram or 3 milligram glimepiride is being used, then you put it into 0.5 unit, because if you suddenly if you omit sulfonylureas, what has been seen practically, you never know how much sulfonylureas are working, and it is very tough to equate the dose of sulfonylureas with insulin dose. Otherwise, there will be high blood sugars, fluctuations will be there. So it is better to get it. Most of the international guidelines and guidelines, they say that you remove sulfonylureas altogether once you are starting with parenteral insulin. But practically it is, most of us are continuing with small dose of sulfonylureas, 0.5 or even 1 unit of sulfonylureas, glimepiride can be continued, and you up titrate the dose of premixed insulin and try to achieve glycemic control, and then you remove it off sulfonylureas slowly. So how to go with the BD dose? 0.2 unit per kg body weight per day. That gives you total daily dose, and with the total daily dose, 2/3 in the morning and 1/3 at night. That should be your human human premixed insulins. Or if you are using analog insulin, it has to be divided into half and half, 50-50. Then how to intensify? Third dose. Now, how to add third dose? That is before the lunch, 10% of the total daily dose that you can add. That is, most of the time it comes around, or you can start with 4 unit with the lunch. So that will give you the plus. If you added lunch dose 4 unit, then you have to subtract something from the premix, from the pre-breakfast dose by 2 to 4 unit. You remove 2 to 4 unit from the pre-breakfast dose. You add 4 unit with the lunch dose, and you continue with the same with the dinner dose. So this is how you can intensify with the TDS dose of premixed insulin. So friends, I will stop here, and I will be happy to answer the questions. I thank you all for the patience hearing. Hello, Rahul, can we have questions? Hello. 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 हेलो, हाँ निखिल, वो फिनिश हो गया? क्वेश्चन आंसर्स हैं क्या कोई? नोबडी इज अटेंडिंग. हेलो.
हेलो हेलो हेलो.
हाँ जी सर, हाँ जी।
हेलो, हाँ सूरी, हाउ आर यू, कैसे हो?
गुड आफ्टरनून सर, गुड आफ्टरनून।
और सब फाइन। तुम्हारा लेक्चर में स्टार्ट किया था, फिर मैं सुन नहीं पाया बीच में भी। अब लास्ट स्लाइड सुनी है तुम्हारी मैंने बस।
चलो वही बहुत है सर। दैट वाज द क्रक्स।
और सब ठीक है? ठीक है।
हाँ जी सर,
सब फाइन, सब ठीक है।
हाँ जी सर।
मैं स्टार्ट तो कर दिया था, ज्वाइन तो कर लिया था मैंने, बट बीच में
Okay.
एक दो पेशेंट थे।
हाँ
जो
जी।
पेशेंट भी दोपहर को ही आते हैं, शाम को, दिन में तो
हाँ,
आते हैं नहीं, सवेरे
ठीक
तो।
बात है। हाँ जी, ठीक बात।
नहीं, और सब ठीक है।
बढ़िया बढ़िया सर, बढ़िया।
अच्छा, एक ही बताओ, जैसे तुम ये प्रीमिक्स देते हो, जैसे ना कई बार कहते हो, जैसे अगर मॉर्निंग में रैपिड दे दें, रैपिड, और दोपहर को रैपिड दे दें, रात को मिक्स प्रीमिक्स दे सकते हैं क्या? ऐसे कर
हाँ
सकते
जी
हैं
सर,
कई बार?
यस सर, यू कैन गिव दिस,
नहीं?
यू
क्योंकि
कैन,
कई
yes।
बार 4
हाँ जी, हाँ
शॉट
जी,
या 3 शॉट में काम चल जाता है ना कई बार।
बिल्कुल 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 चल जाता है सर। बस वही है कि द प्रीमिक्स व्हाट यू आर गिविंग,
हाँ
अगर आप ह्यूमन मिक्सटार्ट 3070 यूज करते हो तो दैट इज एनपीएच,
हाँ हाँ
that will be covering only half of the part. Then again basal will not be there in the full morning dose.
हाँ हाँ
Then if you are using premix analog insulin, then again that will be there, because that is also intermediate acting as protaminated aspart or
yes yes
protaminated lispro is again
हाँ
intermediate acting. So that is the thing that you have to see, that if it is giving you 24-hour control or not.
हाँ
But
हाँ
otherwise you can try this if your patient is
you one
specifically in
can try
time.
it, otherwise
Yes,
no,
you
no.
can try it. Yes, yes.
Yes, yes, okay. चलो, और सुनाओ।
बढ़िया बढ़िया सर, फाइन फाइन।
तुम्हारा इस लेक्चर की स्लाइड भेज देना, भी मैं देख नहीं पाया
हाँ
मैं।
जी, वो मिल जाएगी सर आपको,
है
जरूर
वो
मिल
तो
जाएगी।
आप बीच में आ नहीं रही तुम्हारी स्लाइड कई बार से।
देखिए, हाँ
हैं?
देखिए सर, भेज दूंगा, भेज,
तुम्हारी
थैंक यू
वो
सर।
भी रहेगी, डॉक्टर चंडालिया वाली भी रहेगी भेजनी।
नहीं सर, वो भेज दी मैंने।
अरे नहीं भेजी, नहीं भेजी, भूल
अच्छा
के,
चलो, भेज दो, भेज
भूल के।
भेज दो।
यार आज वाली भी भेज देना, अभी याद
श्योर
करके
श्योर,
भेज देना फिर।
ठीक है,
अभी भेज देना अभी।
भेज दो,
है?
श्योर सर, श्योर,
नहीं,
भेज दूंगा।
पेशेंट देखने से पहले।
ठीक है सर, ठीक सर, भेज दूंगा,
चलो
श्योर।
ठीक है,
ओके,
ठीक, राइट राइट,
चलो,
ओके।
हेलो राहुल, हेलो।
राहुल जी नहीं सुन रहे तुम्हारी बात अभी।
हाँ वही है, लग रहा है, पता नहीं कहाँ चले गए।
गायब, होस्ट जी गायब हो गए, होस्ट
हाँ
है।
हाँ
दोनों होस्ट हैं, एक होस्ट है, एक होस्ट है।
हाँ।
दोनों का नाम राहुल जैन लगता है।
हेलो राहुल, कोई भी नहीं है वो, है? ओके ठीक है, फिनिश कर दो।
चलो
चलो फाइन सर, ओके बाय सर, बाय
ओके, ठीक है,
बाय
राइट राइट
बाय।
राइट, ओके।